There is a quote from Benjamin Franklin which says, "An ounce of prevention is worth a pound of cure." Franklin was actually talking about the fire safety in Philadelphia in his time. However, the idea that prevention is better than cure applies as much to health as anything else. And perhaps it is the intuitive nature of this statement that makes prevention one of the most straightforward principles of public health practice. There is also a moral argument that we should avert disease because it's the right thing to do. And then there is a frequently quoted economic argument that spending money now will save you money down the line. So it's that simple. We should do more prevention, and yet we don't. On a personal level, every one of us every day makes unhealthy choices. And in health systems, prevention funding is frequently looted to make up for shortfalls in funding acute frontline responsive services. So, why is that? Well, while prevention is intuitively and morally the right thing to do, it can be problematic. Firstly, prevention is difficult. Secondly, the benefits you accrue are in the future and the cost is immediate. Thirdly, because you are preventing something from happening, in practice, it's very difficult to know whether what you did actually worked. Most of us cannot count things that did not happen. So, put together, it means that calculating return on investment is really difficult. Prevention costs money, and when a health system is under pressure, prevention funding is an easy area to raid. In public health, there are three levels of prevention: primary, secondary, and tertiary. In primary prevention is the prevention of disease through the control of exposure to risk factors. An example could be a population-wide strategy to reduce salt intake in an effort to bring down the prevalence of hypertension. Essentially, we are doing something to prevent our population from developing the disease. The two broad approaches to primary prevention are health promotion and specific protection. Secondary prevention, on the other hand, is the application of available measures to detect early departures from health and to introduce appropriate treatments and interventions. It's about slowing the impact of a disease that has already taken a hold. An example could be screening adults for hypertension and giving blood pressure tablets to patients who have just been diagnosed with hypertension. So, primary prevention is about preventing disease from starting, and secondary prevention is about halting or slowing down the progress of disease. Tertiary prevention is the application of measures to reduce or eliminate long-term impairments and disability, minimize suffering caused by existing departures from good health, and promote the patient's adjustment to their condition. This is another layer of opportunity that we can potentially badge as prevention, which seeks to mitigate against the impact of disease. This is often about helping people manage their condition and improve their quality of life living with that condition. An example could be support groups that allow members to share coping strategies or environmental alterations that enable someone to retain their independence. I want to introduce the concept of screening. Screening is in the context of public health, can be defined as the presumptive identification of unrecognized disease in an apparently healthy symptomatic population by means of tests, examinations, or other procedures that can be applied rapidly and easily to the target population. There are two elements to this definition that should be noted. Firstly, screening takes place when you have apparently healthy individuals, that is, at least before the symptoms have been recognized, and more commonly, before the disease has even begun. Secondly, screening involves tests, ones that can be efficiently deployed and often at scale. A screening program is how we deliver screening, and it involves processes such as invitations, testing, advising of results, through to treatment for those who are diagnosed as a result of the screening. The World Health Organization specifies four criteria for an effective screening program with respect to cancer screening. An effective screening program should meet the following criteria: mechanisms for systemic invitation and follow-up for individuals identified by the screening test as having an abnormal finding, participation of over 70% of the target population to be screened, necessary infrastructure and resources to offer the test periodically and to adequately diagnose and treat those found to have a lesion, and fourthly, robust monitoring and evaluation framework to assure quality. So in the public health terms, screening is a substantial area, both in terms of opportunity to improve health, but also in terms of financial and logistics outlay. Needless to say, when things go wrong and mistakes are made, screening programs can be one of the more reputationally risky areas of public health work due to the huge number of patients who will take part. A small error can result in hundreds of misdiagnoses. So screening does not apply to only cancer. It can be employed across a wide range of conditions, including infectious diseases, metabolic disorders, inherited genetic conditions, hearing problems, cardiovascular disease, and so on. So what types of screening are there? We'll introduce 3 types: case finding, targeted screening, and mass screening. Case finding is technically not screening, but it's important to consider here because many clinicians refer to it as a screening approach. Case finding is where the patient comes to see their doctor or other healthcare professional for one reason or the other. And at the same time, that professional checks them for another condition, such as hypertension. This isn't technically screening because there was nothing systematic in how the patient was called or tested. It was opportunistic. But case finding is a method that is employed in public health to improve diagnostic coverage and increase early identification. In targeted screening, a particular population who are at risk of a disease or more vulnerable to its impact are identified, for example, tuberculosis in a prison population. We may want to systematically identify patients with tuberculosis so that we can treat them and ensure that tuberculosis isn't passed around in the prison. This is targeted screening, selecting a population and implementing a systematic approach to inviting, testing, and then appropriate recalling and treating the affected individuals. In mass screening, this is where we deliver screening across a whole population. There may be age or gender limitations based on this. For example, we tend to only screen women for breast cancer, but there are typically huge programs that will invite and test many hundreds of thousands, if not millions of people each year. So screening is a very concrete example of prevention or early identification of disease in practice. It can be a huge force for good, but it comes with its own risk and challenges, and we'll discuss some of these next. So what are the epidemiological implications of screening? It stands to reason that an invasive or expensive test is something that's unlikely to be acceptable if we go around offering it to people who are otherwise healthy. But a less invasive might be acceptable. So we need to know how good this simpler test is. Sensitivity is the ability of a test to detect people with the disease. Specificity, on the other hand, is the ability of the test to exclude people without the disease. So we could use this same test in any population, and providing our laboratory colleagues run the blood test correctly, sensitivity and specificity remain fixed. But there are concepts called predictive values: positive predictive value and negative predictive value. Positive predictive value is the likelihood of having the disease if your screening test result is positive. Likewise, negative predictive value is the likelihood of not having the disease if the screening test is negative. What is really important in terms of public health practice is that positive predictive value and negative predictive value change depending on the prevalence of the disease and the population being screened. Let's look at this 2x2 table of same screening test with sensitivity of 90% and a specificity of 90% deployed into 2 populations, each with 1,000 people. In the first table, we'll see that on the left-hand side is a population with a disease prevalence of 5%. Positive predictive value is 32.1%. On the right hand side, the disease prevalence is 50%. Here, the positive predictive value has increased to 90%. Negative predictive value has dropped as the prevalence increases. This phenomenon has huge public health implications. So, screening cannot be introduced to a population unless you have at least a reasonable estimate of the prevalence of the disease. Screening typically occurs at a large population level. Without knowing the prevalence, you run the risk of a huge number of false negatives and false positives, giving false reassurance or false alarm to each of those groups respectively. So screening tests are typically less than perfect in order to make them acceptable for a healthy population. And the price we pay for this is uncertainty. Uncertainty manifests in false positives and false negatives. False positives result in unnecessary psychological morbidity and further invasive tests that may cause more harm than is actually alleviated. Screening is more than simple mechanics or a database of patients' addresses. Our role as health professionals is to anticipate and mitigate against the risk that uncertainty brings. Screening is a powerful tool in our approach to prevention and early identification, but should be used carefully. Unintended consequences can be substantial. So, what are the risk, bias, and consequences of screening? Screening is a tool that we can employ to prevent disease entirely, or at least identify disease or its precursors sooner. Less affluent communities tend to be less resilient with higher levels of disease and disability. So mass screening approaches and universal offerings should help those communities achieve better health outcomes and potentially reduce inequalities, right? Well, the answer is no. Often, screening doesn't reduce inequalities, and sometimes it widens the gap. Screening programs involve these large call recall systems. These will often involve a very large computer database with an administration that systematically identifies all those eligible, sends out invitations, and arranges appointments. The administration will then capture the findings of the test and issue results, advise, or indeed refer the patients for further testing or intervention. What do we observe among those who come forward for testing? Well, we tend to find on the whole that they are more likely female, older, more affluent, and perhaps, most importantly, more healthy. So we have seen how the epidemiology of your screening is contingent on both the test employed and the prevalence of disease in your population. But what is your population? Your population could be the eligible population, that is those invited, or the tested population, that is those who actually attended. Now, if tested population is systematically more healthy than the eligible population, your positive predictive value and negative predictive value are not going to hold. Your positive predictive value will go down and your negative predictive value will go up. Notwithstanding your epidemiology, both assuming your screening programs leads to better outcomes, the effect will be to eventually improve the health status of the tested population. Now, if your tested population was more affluent and were more healthy to begin with, you would have succeeded in making richer people even more healthy. In doing so, you have widened health inequalities. This is an example of self-selection bias, where healthier, more health-conscious people come forward and take part in the screening program. In practice, we try hard to reach those most vulnerable communities. Simple things such as ensuring screening information is available in different languages, employing outreach workers, through to taking screening out in mobile units to geographically isolated communities are some of the approaches that we use. You always need to consider who is going to benefit from the screening program. So there is one apparent statistical upside for public health specialists and epidemiologists and having healthier people come forward for screening. If you compare the health outcomes of those who had been screened against the general population, the screened population will look healthier. You might optimistically ascribe that to delivering a fantastically effective screening program. That may not be, and probably isn't the case, because people came forward for screening are healthier, then they would likely they would like to stay healthy and therefore will have better outcomes than the general population, probably, and against the on-screen population, almost certainly. This is an example of how self-selection can bias your evaluation of screening programs, leading us to incorrectly assume that they are effective. There are two other types of bias that arise in screening programs that likewise can lead us to overestimate the benefits. These are lead time bias and length time bias. Screening, by definition, seeks to identify precursors or early stage disease. Let's say a patient is destined to die in 5 years' time. In scenario A, they get symptoms in 4 years' time and die a year later. In scenario B, they are screened tomorrow and diagnosed next week and die about 5 years after. In both circumstances, they die in 5 years' time. Only in scenario B, having undergone screening, the patient was diagnosed earlier. If the measure of screening program effectiveness was survival, then survival in scenario A was 1 year. In scenario B, it was 4 years. Well, it looks as though screening was associated with an additional 3 years of survival. So the screening program is brilliant, right? No, it wasn't. The patient still dies in 5 years' time. In fact, the screening results only gave them 3 additional years advance notice of health. So this is what is called lead time bias. Let's look at length time bias. Cancer is not a single condition. In fact, the term cancer covers a range of underlying disease processes characterized by invasive cellular proliferation. To simplify, cancers are different. Some are aggressive and some are not. Aggressive, or what is called high-grade cancers, spread more quickly and therefore kill more quickly. So let's take 12 patients with cancer onsets at different stages over 5 years. Half of them have high-grade or quick cancer, and the other half have low-grade or slow cancer, and we screen them. Patients with slower cancer will have longer periods of time in the earlier stage of disease. They are therefore more likely to be detected by screening. Now, our screening program has detected 5 of the 6 with a low-grade cancer, with only 3 of the 6 with high-grade cancers. Let's say survival was the measure used to evaluate our screening program. Low-grade cancers kill more slowly. Therefore, because our screened cancer patients are more likely to have a low-grade cancer, the survival of the group on average will be higher than we would observe in an unscreened cohort. So once again, we incorrectly surmise or conclude that our screening program is fantastic. Yet all we have done is identify low-grade cancers and infer that the survival advantage is down to them being screened. This is what is known as length time bias. So we have seen the 3 types of biases that arise when evaluating screening programs: self-selection, lead time, and length time. Your future colleagues and stakeholders may come to you with ideas for screening or more likely interventions that apply principles of screening as components, and such as case finding. It is vital that you are alert to the biases that can arise when introducing screening approaches, as you may otherwise come to incorrect conclusions about how successful your screening project has been or will be.